You're working a late night shift in the emergency department when you get a call overhead to resus. You look in and you see a young guy who's drowsy with vomit all over his shirt. He's dripping with sweat and appears to be breathing really quickly. The paramedic that brought him in mentions to you that this guy told them he swallowed a pesticide that he brought back from his native country of Bangladesh about 2 hours ago. Your alarm bells start to go off. This guy is not looking good. His vital signs support your instinct. He's got a heart rate of about 40, and his blood pressure is around 90/60. Monitor is giving you a reading of an oxygen saturation of about 84%. Just before you go examine him, something tells you, I should probably get all gowned up. So you don a mask, a face shield, a gown, and some gloves. As the nurse is applying oxygen, you listen to his lungs. There's crackles and wheezes all over. Just before leaving the room, you look in his pupils. They're pinpoint. If you're asking yourself, could this really be a case of an organophosphorus pesticide poisoning here in my ED in North America? Well, you would be right. These cases just aren't something that we see every day. But across the globe, there's over 200,000 cases of acute pesticide poisoning seen every year. And occasionally these patients do present to us. Organophosphorus compounds are pesticides that work by inhibiting that acetylcholinesterase enzyme. Other compounds like carbamate pesticides or nerve agents like sarin, for example, inhibit this enzyme too, and the clinical picture of presentation is really almost indistinguishable. These patients classically present with the cholinergic toxidrome. Here, I like to fall back on a little bit of pathophysiology to help me remember what's going on. Basically, there's excess acetylcholine at the muscarinic receptors in the parasympathetic nervous system. So patients can have diarrhea, vomiting, drooling. They might be incontinent of urine, and they're often going to have pinpoint or myotic pupils. There's a bunch of mnemonics out there to help us remember these symptoms, things like dumbbells and sludge. But really, the most important one is that of the killer bees, standing for bradycardia, bronchorrhea, and bronchoconstriction. It's the cardiorespiratory failure that's going to kill these patients and cause serious morbidity. Keep in mind that when somebody's poisoned with an organophosphorus pesticide, they will also get excess acetylcholine at a few other systems. So one, in the central nervous system, causing maybe seizures and lethargy. Two, at the neuromuscular junctions, that's going to lead to fasciculations, weakness, and even paralysis. And finally, at the nicotinic acetylcholine receptors of our sympathetic nervous system. And here we can get a tachycardia and mydriasis, which really offset some of those parasympathetic symptoms I mentioned earlier on and can kind of make your clinical picture a little less classic. To state the obvious, these patients are super sick. They require aggressive supportive care, so oxygen, airway, ventilatory management, IV fluid boluses, and diazepam if they're seizing. Take a moment here to ensure that your team has appropriate personal protective equipment on. And as soon as possible, try to decontaminate the patient. So remove any clothing that's got vomit or maybe the pesticide on it. And when there's a chance, try to have somebody clean their skin with some soap and water. More than anything else, there's a couple of really important antidotes that we need to be giving as part of this resuscitation. The first, and definitely the most important one, is atropine. Atropine is going to block the muscarinic receptors in the parasympathetic nervous system, and it's going to lead to improvement of that cholinergic toxidrome. The best way to give it to these patients is by following the dose doubling protocol. So give 1 to 2 milligrams of atropine to start, and then reassess your patient for persistent signs of toxicity about every 5 minutes. If they're still toxic, give another dose of atropine at double that initial dose. Continue to double the dose every 5 minutes until your patient has a clear chest and is more hemodynamically stable. So like their heart rate's about over 80 and they're, for example, not hypotensive. At that point, you're going to start an infusion of 10 to 20% of the total dose of atropine per hour. There's no maximum dose of atropine. Some patients can need well over 100 milligrams, although in a moderately poisoned patient, it's usually around 40 milligrams. It really depends on the dose and the type of pesticide that this patient's been poisoned with, and we actually rarely know that exact info. The second antidote to give is a drug that's going to restore the acetylcholinesterase enzyme. Here in North America, we use pralidoxime, which is also called Tupam. The evidence around giving pralidoxime is a little bit murky, but there's really very little harm, and so it's generally recommended to do so. There's no evidence to guide dosing, so make sure that your poison center is involved if you haven't reached out to them yet. They can help guide you. As a final point, these patients are obviously sick. all that atropine's only going to make a difference in treating the muscarinic symptoms. Patients can still develop respiratory muscle weakness despite not showing any signs of cholinergic toxicity. They need to be admitted to a monitored setting and they need to be watched pretty closely. So, in review, poisoning with an organophosphorus pesticide presents most classically with symptoms of the cholinergic toxidrome. Think about your parasympathetic system in overdrive and those killer bees of bronchorrhea, bronchoconstriction, and bradycardia. Remember, though, that they can also be weak, be seizing, and lethargic. Aggressive supportive care and antidote therapy with atropine and pralidoxime are indicated. The way to give atropine is to follow that dose doubling protocol. Start with 1 to 2 milligrams and then double the dose every 5 minutes until your patient's got a clear chest and is hemodynamically stable. At that point, you're going to start an infusion.
So, huge parasympathetic nervous system activation with these cholinergic pesticides and sarin organophosphates, which of course causes wet stuff. Diarrhea, pee, vomit, salivation, tears pouring down the face, fluid filling the lungs. I jog my memory by thinking of it as the opposite of an anticholinergic toxidrome that we see a lot more of. But the really important deadly effects in the initial resuscitation of these poisons are the killer bees: bradycardia, bronchoconstriction, and bronchorrhea. Give atropine in big doses, 1 to 2 milligrams IV to start, then double the dose every 5 minutes until they're hemodynamically stable, then start an infusion. And don't forget pralidoxime for your exams.